Okay, guys. Hi. Today I'll be doing the small, very basic video lecture about the CNS pathology and the basic concepts about the CNS pathology. We're gonna cover the pretty basic stuff, and maybe on the next lectures we're gonna cover things in much more detail. But still, let's kind of start, and I'm going to do a lot of things today, not just the PPT presentation, but a lot of interesting things. I'm going to try at least. So, the first thing I want you to remember well, what is the normal histology of the CNS? How does the brain actually looks like? Because if you don't remember that well, then you won't understand what's the pathology in the histology. So what's the morphologic diseases, morphologic manifestation of the disease. So that's the normal histology. Now what's actually happening here, I think you should be seeing my arrow here. That's the neuron. That's the body or soma of the neuron, and that's an axon of the neuron with a little projection here. There's also a neuron, but this is like a very classic, very beautiful, extremely good picture. What do we see in that neuron? We see the axon, okay? We see the nucleus. We see the nucleolus, one very fine and beautiful nucleolus, and we see something strange. Those small purple parts, which is actually an endoplasmic reticulum, but the endoplasmic reticulum of the like a rough endoplasmic reticulum of the neuron is called the Nissl substance. So please remember that this guy is a Nissl substance. We're gonna need that in pathology. Okay. So that's the neuron, What are all those other things? Now this is a cell, like a lot of cells that you see in nuclei, the ones you see here. All of those are glial cells. The glial cells that constitutes, for example, not for example, exactly 90% of the CNS tissue. So neurons are just like 10%. Like everything else, like 90% approximately is glia. So what are glia? There are like different glial cells, like the astrocytes, microglia, and so on and so on. We're gonna you have to know that already, but I'm gonna talk about astrocytes a bit later. So now let's go and look how the damaged CNS tissue looks like. One of the main things you have to remember is how do the damaged neurons look like. Now, pycnosis, all of those are the signs of that. Pycnosis is the shrinkage of the nucleus. Like this is damaged neuron here. So there is not very well visible nucleus. There's a cell shrinkage. Look at the cell, how like small it is. Now this guy is big, right? Round and beautiful. This guy is not as big and round and beautiful. It's shrunken. There's absent nucleolus. Remember how well did you see nucleolus? There's no nucleolus here. There is loss of Nissl substance. Remember how well did you see Nissl substance here? All those purple patches? Not here anymore. Not here anymore. No Nissl substance. And there's an extreme eosinophilia of the cytoplasm. In here, in a normal one, it's not that eosinophilic. Look at that. It's not pink. It's like light and dark purplish, right? And in here, it's like too pinky, super pinky. So it's sometimes called a red neuron. So when you see the word combination red neuron in a test or somewhere, you should know that they're usually talking about the damaged neurons. Neuronal damage. What do you see in here? That's probably, I think, should be an astrocyte. That's on that guy, and that should be a microglia. I'm not sure, but probably it should be like that. So next, now gliosis. I don't have a lot of text here, so I'm usually mainly speaking. So you have to really listen to me. What is gliosis? Imagine that when I damage some part of the nervous tissue, you know that neurons cannot regenerate. And because the neurons cannot regenerate, the space that was left after the neurons died should be filled with something. And that something are glial cells. And those glial cells grow there in like free space and just fill the space. And that phenomenon is called gliosis. So what is gliosis? It's actually making the scar in the brain. So that scar tissue is called the gliosis, but doesn't look like a scar at all. So you killed neurons, you killed the CNS tissue, that CNS tissue all died. If you remember, that's a good thing. I remember the good thing. If you remember, we did that in like the third semester when we started pathology. I taught you that the damage in the CNS results in the liquefactive necrosis. Liquefaction, that means that the necrotic tissue gets liquid and just disappears after some time. So there, in the like tissue, there's like free space left. It's not a coagulation necrosis. It's actually a liquefactive necrosis. So that free space has to be filled with something, and that something is the glial cells. So that's called the gliosis. Now, the main glial cells are astrocytes, which multiply and grow. And I want you to remember that this is how astrocytes look like on a normal smear, H&D smear. Okay, these are also glial cells. These are probably microglia. And here you see the astrocytes. Look at those astrocytes, absolutely different. As you see, they have different types of nuclei than the glial cells have, than the microglia have. Microglia are the macrophages of the brain, right? So in here, on the right hand side, there's absolutely different type of the histologic section, which is treated with a special dye, which dyes the GFAP. Now, what's the GFAP? It's called the glial fibrillary acid protein. Please remember that glial fibrillary acid protein is characteristic only to the astrocytes. So now look at that. Now you might know why those cells are called astrocytes. Astro means a star. That's where the astrology comes from. So astro means a star. If you look at this guy, looks kind of like a star. All of them kind of look like stars. So in here you don't see the starry fashion. In here you see a starry fashion because this is stained by the special stain that stains the GFAP, glial fibrillary acid protein, which is only characteristic to astrocytes. If you see a tumor which is GFAP positive, it means it's an astrocytoma. Okay, I'm gonna show you another picture of astrocytes. The same GFAP stain, where you see that they look like much more like stars than the previous picture. Okay, so gliosis. Oh, just remembered. Wait, I have to show you gliosis in here. There was a very good picture. Yeah, here. Now look at that. This is the CNS. Okay, that's an absolutely normal tissue. We can actually zoom in. That's why I just chose that picture. Hey, zoom in, bro. Come on, here. Okay, so here you see some astrocytes here. That. This is some neurons. And in here, what's happening in here? You see a big difference between that and that. All of that is like free of small black bodies. And that part is like full of small black bodies. What are those black bodies? Those black bodies are actually glial cells, microglia, and you'll also be able to see astrocytes like here, and so on, like that one, and so on. So what probably happened, there was a damage in here, and then the glial cells just grew in here and produced this kind of a picture. The same kind of happens in this part. Okay? So this is not damaged, and this is damaged, and then repaired. So remember those small blue dots. Okay? Now, small blue dots and blue bodies, or black bodies, is up to you. Like 1 or 2 or 3, 4, in small amounts are in here, but not as much as in here. Okay? So this is a damaged and then repaired. This is probably not damaged and happy. I don't know. Okay. Now, I'm going to get back in here. I'm gonna still play and go on. Now, I want to discuss the cerebral edema. Cerebral edema is, you know what is edema? It's a swelling. It's an accumulation of too much fluid in the tissue. So, cerebral edema would be edema of the brain. Okay, and why is edema of the brain that bad? I'm gonna tell you why. Imagine that your brain is actually swelling in your head, and the main problem is that your head and your cranium, your bones, are not flexible. Your cranial vault is a very fixed compartment. Because of that, when the brain swells in a very fixed compartment, the brain tissue, which is very soft and fluffy and lovely, it's like a flubber, that fluffy brain tissue, how to say, compresses the bones, but bones don't get damaged. A brain tissue becomes damaged by the compression. So because of there's a high pressure in the cranial vault, the main damage is towards the brain tissue. So whenever there's a cerebral edema, sometimes, as I know, I'm not very sure, but sometimes, as I know, neurosurgeons have to open the skull to just open the space for a brain to swell and give the doctors time to treat the patient for swelling. Because if the brain continues to swell and it doesn't have the space to grow somewhere, then it will be like extremely damaged in a very small amount of time. Okay, so that's why the damage during the cerebral edema, the main type of damage, of course there are different types of damage, but main type of damage is because of the compression of the brain tissue during swelling on the inner surface of the cranial bones. So now, there are two types of edema, as you see. There's a vasogenic edema and the cytotoxic edema. The vasogenic edema, the word tells you kinda, it's a blood vessels, genic, generating edema. So it's because of the blood vessels. What happens is there's a fluid leaking from the vascular space to the extracellular compartment. So usually it's because of the blood-brain barrier damage, when the blood-brain barrier cannot hold the liquid in the fluid in the blood vessels anymore, or there's a meningitis, the inflammation of the meninges, and so on and so on. So everything that will make the vascular epithelium more permeable towards the water will give you a vasogenic edema. Now, and the vasogenic edema can be localized or generalized. There's like both of them. You're gonna read the more precisely in the book. And the cytotoxic edema, also the name tells you, it's a cyto, cell, toxic. So it's a cell toxic edema because of cell toxicity, and it's the very classic edema. If you remember, also the first chapter of the pathology book, the Robbins pathology, tells you that every type of damage of the cell gives you edema of the cell, like cell swelling, because of the lack of ATP. Lack of ATP gives you dysfunction of the sodium-potassium ATPase channel, which doesn't put the sodiums out and potassiums in. Sodiums stay in, and because of that, sodium drags water inside. Water goes inside of the cell and gives you a swelling. So that's the same thing, but in the CNS tissue and CNS cells. So as you see, it says intracellular swelling due to the neural and glial damage, and which is usually following hypoxic to ischemic injury. One more thing, yeah, we have to remember that hypoxia just gives you lack of oxygen, no ATP, and so on. Ischemic injury, no blood, no food, no energy, and so on and so on. Same thing, no energy, no ATP, and as I already said. So I want you to remember that vasogenic edema is mainly extracellular compartment edema. Okay? It's a tissue edema, but it's extracellular compartment edema. And cytotoxic edema is the intracellular edema. So if I make some kind of comparison, vasogenic edema is the same thing as the pitting edema in the legs. Mechanism is the same, because the pitting edema is the edema of the extracellular compartment of the skin caused by the heart problems, and cytotoxic edema is close in comparison with the edema of hyponatremia, which makes you drag the extracellular fluid into the intracellular fluid, so on. Okay, so let me get to the next picture. So this is the still cerebral edema. I just want you to know how does it actually look like. And there are like two, like on the left there's an MRI, on the right there's a CT, but it doesn't really matter. On the MRI, what do you see here? It's a brain. Hello. Don't mention those things yet. Just look at the surface. You see those black small lines, like here, also here, 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 here. If you remember the neuroanatomy, these are the sulci. One is called sulcus. The multiple are called sulci. Sulci are the invaginations or the growths or something in the brain tissue, like infoldings in the brain tissue, and there are gyruses or like gyri, one gyrus, several gyruses, like gyri. Okay, so this is a gyrus. So between two sulci there's a gyrus. Between two gyri there's one sulcus, and so on. It's like a mountain and the fall, and mountain and the fall, and mountain and fall, and so on. So imagine that if there's a brain swelling, because there's an increased pressure there, the brain grows, swells towards the brain, towards the cranium, like that way, that way, that way, that way. And that's why that surface gets pushed on the bone, and all those things get flat. They got flattened. And because they're flattened, you don't see them anymore. Look at that. Do you see lines? Do you see sulci? Or do you see gyri? No. Because they're flattened. So when you see the CT or MRI, but usually you'll see the CT of the swelling, like that, when you don't see the sulci, you don't see the gyri, think about edema. And you should know that cerebral edema is a medical emergency. You should definitely do something. One of the good choices is give somebody mannitol injection. What is mannitol? Mannitol is hyperosmolar agent, which makes your blood hyperosmolar. Hyperosmolar means that your blood will be more osmotic, in an easy words, more salty, and it will drag the water out of the cells and into the vascular compartment. Why do we need that? Because there's a swelling, there's more fluid in the brain tissue. I'm gonna just draw that fluid back to the vascular compartment because I made my vascular compartment more osmotic. So there's a more osmotic pressure there. Okay, so let me jump. Now I jump to the hydrocephalus. And at first I'm gonna give you that easy way of how does the ventricular system of the brain look like. Then I'm gonna leave that program for a moment, jump to a very cool program that gives you the full MRI scan and show it there, and then come back to the lecture. So, okay, there are 4 ventricles in the brain. There are 2 lateral ventricles. They are not called like first and second ventricles. They are lateral ventricles. Then there's a 3rd ventricle and there's the 4th ventricle. Now, 2 lateral ventricles drain into a 3rd ventricle by the foramina of Monro. So 1 Monro, 2 Monro, 1 Monro, 2 Monro. Those surnames are being forgotten already, and we have new names without surnames, which make more sense. And now they're called interventricular foramina. So one interventricular foramen, another interventricular foramen. But you still have to remember the older names, because a lot of people, especially like doctors nowadays, who have learned the names, the older names, still use it. So you have to know the both. Now the 3rd ventricle drains into the 4th ventricle by the cerebral aqueduct, or the aqueduct of Sylvius. You should know both, remember. And the 4th ventricle is the last part. 4th ventricle drains into the subarachnoid space by the 2 foramina of Lashka. So there's like left and right Lashkas, or Lushkas, and 1 Magendie, which is posterior to the 4th ventricle, like between the brainstem and the cerebellum. So, and yeah, obviously there's a small drainage into the spinal cord in the central canal, which doesn't really matter in this instance. Okay, so imagine that the what's that fluid called? Cerebrospinal fluid is generated in the lateral ventricles. Then both lateral ventricles drain into the 3rd. We also generate the CSF, cerebrospinal fluid, in the 3rd ventricle. Then all of that fluid goes into the 4th. We also generate it in the 4th, and from the 4th, all of the fluid goes to the subarachnoid space, and so on. So now I want us to stop and look at the very cool program which I adore, and it is called the Brain View, and we have it here, and it shows you the brain. Just look at that. It's amazing. It's beautiful. Unfortunately, I cannot make it bigger, but maybe I can make a screen bigger. Let's try at least. It says no. Okay, so now look at that. We have all 3 views. This is the transverse section. This is the sagittal section. I can move it like that. And there's the coronal or frontal section. The easiest is the transverse one, so I'm going to start with the transverse, okay? And I'm going to go from the top to the bottom. Okay, so let's start. We're going, we don't see anything, Here, the skin. The skin, then comes the bone. Okay, so this is the skin. This is the, subcutaneous tissue. This is the first part of bone. Now look at that. You see a suture. See? Suture, suture. That's the sagittal suture and the frontal suture. Okay, we go down. You see the brain already. Hello, brain. The frontal suture, sagittal suture. Hello, brain. You see a dura mater here, meninges, and you see a falx cerebri, a midline part of the dura mater. Now we go down, You see the cortex very well, you see the white matter very well. We still go down. Okay, beautiful. See the connection between the 2 hemispheres? That's the corpus callosum. I just remembered somebody asked me what's corpus callosum. This is the so corpus callosum, by the way. Okay, now, what's that? A free space. Oh, do I have a hole in my brain? Really? Yeah, some of you do, guys. Maybe even bigger ones. But these are the lateral ventricles. Now look at that. Why are they called lateral ventricles? Because they're lateral. They're collateral. So I'm going still down. These are still the lateral ventricles until they go into the third. Where's the third here? Okay, here it is. See that? The small openings which drain into the very thin one, that's the third ventricle. These are the foramina of the Monroe or interventricular foramina. Now we're going a bit down. If you're interested in the MRI, we can talk about that and discuss all the MRI very well in class or somewhere. We don't have the time here. Or you can actually request the video lecture about just an MRI, and I'm going to do that like differently. But okay, I'm going even more down, and what I see here, this is still a part of the lateral ventricle. What I see here, it's the, okay, wait. There's the foramen of the aqueduct of the Sylvius, which gets me into the fourth ventricle. Wait, here. Okay. No, that's the third ventricle still. Third ventricle. Here. That guy. Look at here. And when I move it, you're gonna see a small foramen here. That's actually midbrain. Look at that. See the foramen? See that? It's a like aqueduct of Sylvius, which is going to open. It's still the aqueduct of Sylvius, which is going to open and become big. That is already a fourth ventricle. Fourth ventricle is between the pons and the medulla oblongata and the cerebellum. So there's a pons, there's the cerebellum, and these two, by the way, the like pedicles which connect the pons to the cerebellum are the middle cerebellar peduncles, and then it's over. Okay. So this is how the ventricles look like in the transverse section. One more time. The lateral ventricles, which then drain into the third ventricle, which then drains into the, in here, aqueduct of Sylvius, and the fourth ventricle in here. Okay? Now let's look at that from the front. Let's go. Nose, lips, eyes, doesn't really look like beautiful. Teeth. I'm going into a cranial cavity already. Okay. Brain, anterior part of the brain, eyes. There's a tongue already. There's a nasal cavity and the maxilla. Okay, I'm going in. You see the brain tissue, you see the gray matter, you see the white matter. And the first thing that you see would be lateral ventricles. Here, see? The opening of lateral ventricles. Beautiful. Now we go lateral ventricles, which is gonna unite. Moment. Oh, here. See? The very thin third ventricle and lateral ventricles drain into the third ventricle by the foramen of Monroe or interventricular foramina. Okay, I'm going back, right? So this, as you see, is the aqueduct of Sylvius, which is going to open. Okay, this is an extremely beautiful picture, if you ask me. That's the brainstem and the spinal cord. This is the pons. This is the medulla, and this is the midbrain. In back, you can see the part of the cerebellum. And remember, I said the fourth ventricle is between the cerebellum and the pons. So I have to go past the pons, and then I'm gonna get into the fourth ventricle. See? So I'm going from the front, I see the pons, I go a bit back, and bam, I see the fourth ventricle. I'm gonna get a bit more, and see here? See here? There's the fourth ventricle. And then I got the cerebellum. There are still lateral ventricles going back. And now it's over. And I'm gonna go back and finish it. Okay? One more time. Lateral ventricles, then they unite, they get into the here in the, see that? Drain into the third ventricle goes down, I see the pons, there's the, here the pons, and in the pons, bam, I see the fourth ventricle, here to the fourth ventricle, and that's it. By the way, you can download that brain view, it's on the any type of iOS, iPhone, iPad, I don't know what else, and a Mac, obviously. It's free, it's very user-friendly, and so on. And one more time, let's go do it from the left to right. So I'm gonna start from the left. Go ear, guys. The first thing, ear. Arteries, extremely well seen. See that? Extremely well. Like, look at that. Look at that. It's so beautiful. External. It's an external wall. Here we have to see like internal. What is that? Who cares? Okay, the brain. The eye. This guy, I don't know. He doesn't have a nose. That might be the MRI of the Voldemort. I'm not sure. Okay, there are no ventricles yet. That's the starting point of the left, lateral ventricle. Now see that that's the ventricle already. Lateral ventricle, which is okay. Here's the corpus callosum, very beautiful. Here's the pons. Here's the medulla. Here's the midbrain. There's the cerebellum. Let me wait. Okay, one more time. Lateral ventricle. There. Oh, no, not there, not there. Here, there's a fourth ventricle. See? Between the pons and the cerebellum, in the middle. Fourth ventricle. There's the third ventricle. See? Third ventricle. Just below the corpus callosum. I'm gonna go a bit right. More right. And now this becomes the third, lateral ventricle one more time. But I want you to show the exact parts where the you won't be able to see this in here. Okay, it's okay. So now you understood it a bit, and now I want you to show you the here. Get back and tell you what is hydrocephalus. Hydrocephalus means hydro, water, in the cephalus, in the head, water head. Hey, water head, like that. So what's happening is that the fluid is accumulating in the ventricles, and it usually has two reasons. The hydrocephalus can be obstructive, can be non-obstructive. So obstructive means that there is an obstruction somewhere on the way. There's an obstruction here, this guy will grow. The accumulation will be here. All of that else will be okay. The obstruction is here, there will be an accumulation. If obstruction is in here, here, we will have the accumulation. If the obstruction is in here, I'm going to have the accumulation everywhere. So it's logical, right? There's obstruction and the fluid doesn't flow anymore. And it grows. Like the proximal part of the system grows. But the thing is, all of those are obstructive ones. But sometimes we have, like, some guys have the unobstructive, like non-obstructive ones, when you don't know what is the reason actually. Actually, there are some reasons, we're going to talk about that much later. You have to, like, never mind that. Okay? So, just the pictures. Okay, remember how did they look like? This is the normal type of lateral ventricles. This is the hydrocephalus lateral ventricles. See how big they are? because there's an accumulation of the fluid, because the fluid doesn't flow. Now look at that. Look at that. Lateral ventricles. Just look at those. How big they can be. They can actually just atrophy the whole brain tissue. Now, why does the brain tissue atrophy? Because there's accumulation of the fluid, increases the pressure. And remember, the brain tissue is very fluffy and lovely and very soft, so it gets damaged very easily. And when you raise the pressure so much, of course it causes a lot of headache. But it also causes the brain tissue to be damaged and atrophied. So that's what happened here. Like, look at the atrophy. There's no brain tissue anymore in here. These are the lateral ventricles and the part of the third ventricle in here, with a very dilated foramen of Monro's. And on the other picture on the right side, you see an extremely dilated third ventricle. And as you see, the fourth ventricle is okay. So there probably should be an obstruction between the third and the fourth ventricle in the cerebral aqueduct. Frankly, I don't see one in here. Maybe I'm just not seeing it and it's in here, but maybe the picture needs to be moved to see where's an obstruction. You may actually. Probably, usually there are the tumors of the pineal gland which obstruct it. One more thing. Now, you see the hydrocephalus in the fourth ventricle. Look at that, how big it is. There's a pons, there's a cerebellum, extremely big, fourth ventricle, also the dilation of the third one. And in here you see the dilation of the lateral ventricles, and there's the fourth ventricle, which is also very big. Okay. Whew, we are both tired. Cool. I don't have a lot to do, actually. I'm finishing very soon. So, neuroanatomy, meninges. I just want you to remember how do the meninges look like, because they will be very important to know anatomy, like after we do that. Next thing is the hemorrhages. So I want you to remember how does the anatomy look like. There's a skin, there's the periosteum afterwards, there's a bone, and there are like two layers of the dura mater. There's the outside layer and the inner layer, okay? Now, what I want you to remember is that those two duras, look at that, go in the middle of the brain. This is the one hemisphere, this is the another hemisphere, and it's the middle. And you get the falx cerebri, which is like two layers of the dura mater together, which is like extremely hard and very hard to move. And it has a much stronger tissue than the brain itself. So if you compress the brain on the falx cerebri, you're gonna damage the brain and not the falx. Okay? Remember that. That will be very important. Below the dura mater, there is the arachnoid mater, and then there's a pia mater. And between the dura and the arachnoid, there's a subdural space. Below dura, subdural, below dura. Between the bone and the dura mater, there's an epidural space, and between this arachnoid and the pia, there's a subarachnoid space. And if you look at the subarachnoid space, there's an actually real space there, which is filled with the CSF, cerebrospinal fluid. So when the fluid comes from here to here to here, then it goes to the cerebrospinal fluid. It actually goes here and circulates, and then goes to venous system and so on. So the thing is, I want you to remember that between the bone and the dura, there is a epidural space. Between the dura and an arachnoid, there's a subdural space. Between the arachnoid and the pia, there's an subarachnoid space. Now, one more thing to know. In an epidural space, we have arteries. In the subdural space, we have veins. Okay? Epidural space, arteries. Subdural space, veins. Because the hemorrhages matter in that instance. Now, difference between the subdural and epidural hemorrhages. The reason of both of them is usually trauma. You just walk into a bar, somebody crazy comes to you and kicks you with a bottle in the head. I'm sorry. So you get the damage. Now, if you have the damage between the bone and the dura mater, and that white thing is a dura mater here, that's white. And if you especially have the fracture of the bone, because the fracture is sharp, it can damage the artery. Remember, in the subdural space, in the epidural space between the bone and the dura, you have the arteries. It damages the artery, and there's an arterial bleeding in the epidural space, sometimes called an epidural hematoma. If you get a bit luckier and get a damage between the dura and the arachnoid, which is a subdural space, you damage your veins and you have the venous bleeding and venous hematoma in the subdural space. Now, that's the logic. Then what's another difference? Another difference is the shape. Now imagine bleeding from the vein and from the artery. In an artery you have a much higher pressure, so the bleeding will be much higher in amounts. Okay? The venous bleeding will be slower, and it might be accumulating for several days. Epidural bleeding, arterial bleeding, is very fast and very big amount. And another thing is very interesting and important is that dura mater is attached very firmly to the bone where the sutures are. Remember that coronal suture, remember that sagittal suture. So imagine that there's attachment in, like, okay, I have to show you that. It's not really easy to understand. Sutures. Suture of the what? Oh, Chetan just posted something. Yay. Sutures of cranial sutures. Cranial. Not crat. No, not crat. Cranium. Okay. So, look at that. Which one would be good? Oh, this will be perfect. But it's small, so it's not perfect anymore. We could use that. Oh, come on. Okay, let it be. It's terrible, but still, let it be. So these are the sutures. So imagine that below the bones is dura mater. And now, in here, the dura mater is very firmly attached. So if I break your bone here and you have the epidural hemorrhage, that hemorrhage goes around, but it can never go past that border because the dura mater is fused here. So it has to stay in here. So that's why epidural hematoma never goes out of the border of the sutures. If it's here, if it's this part, it's going to stay in those sutures. If it's here, it's going to stay in those sutures. Epidural, arterial bleeding. If it's a venous bleed, it has nothing to do with sutures. So if it starts here, it can go over the bounds. Okay? Remember that, please, because we're going to see that now in the pictures. So epidural hematoma cannot go through the boundaries, and that's why it stops here and here and doesn't leave. And that's why it has to be like bigger. It seems to be bigger. And the venous bleeding in the subdural hematoma, it can go as much as it wants to, so it looks different. So the special words you have to remember is that epidural hematoma looks like a lens, biconvex lens, and the subdural hematoma looks like a crescent or a moon. Now I'm going to show you real pictures of those. Look at that. That's an epidural hematoma. See? There is a suture, so it doesn't go like over the sutures or under the sutures. It stays here. So look at the shape. look at the shape. A classical biconvex lens. Now this is a subdural hematoma. See? There is a suture, but it doesn't care. It just goes over everywhere. And look at the shape. It looks like a moon or a crescent. Now, what I want you to remember, what is extremely important, I remember like 5 minutes ago, I said that what did I say? Yeah, I said that the hematomas are usually because of the trauma. So, and they're fast, and it's an emergency. So when somebody brings to you in an emergency unit a patient with a head trauma, you have to detect the hemorrhage. So you have the two choices. Either you do the CT or you do an MRI. And remember, every time you have the choice, 100% go on with the CT. And I'm going to tell you why. The first thing is that it is an emergency. You need an answer, a result as fast as possible. CT takes 7 to 10 minutes. The MRI takes 50 minutes to an hour or more. So you win a lot of time by CT. Another thing is that CT works physically with the X-rays. MRI works with the magnetic stuff. So the thing is that on the CT you see the brain is gray and the blood is white. On an MRI they have the same color. So if you even do the MRI you might not see a difference. So always do a CT when you are looking for the hemorrhage. Okay? Next. Now, we talked about epidural, we talked about subdural, we haven't talked about the subarachnoid. So now let's get there. Now, how can we get the subarachnoid bleeding? We can get it by the aneurysms, usually. So what's an aneurysm? Aneurysm, you should remember that, is the dilation of the arteries. Usually aneurysms happen in the circle of the Willis. It's called the Berry aneurysms, and usually they are congenital and happen in the people who have some kind of the genetic diseases with elastin diseases, like elastin and collagen and stuff. So several, like for example, Marfan's disease and so on. And this is how it really looks like. There's a vertebral artery, there's a basilar artery, and there's extremely big guy who can rupture anytime and kill you. This is a very extremely good picture. I liked it too much. Look at the arteries. Look at that, very very thin. How thin it is. How easy would it be to break that guy and produce a bleeding in the brain? How does the subarachnoid hemorrhage look like? How does it look like? It has a special view, and you have to remember that. Okay, the thing I want you to, before I explain that to you, I have to get back to that picture. And remember that subarachnoid space is between the arachnoid mater and the pia mater. And the pia mater sticks to the brain everywhere. So pia mater goes down here and goes down here, and that is the sulcus, and that's a sulcus, and that's a sulcus, and that's a gyrus, and that's a gyrus. So sulcus, gyrus, sulcus, gyrus, sulcus, gyrus. Okay. So pia mater goes down the sulcus. So subarachnoid space is not tall here, but in here, from here to here, you have the subarachnoid space, because the space is between the pia, which is here, and arachnoid, which is here. So if there is a blood in the subarachnoid space, blood will also go there in those sulci, and you will see the blood in the sulci. Now look at that. You see that? White blood in the sulci. Look at those. Blood in the sulci, blood in the sulci, blood in the sulci. See? That's an indication of the subarachnoid hemorrhage. one thing I have to tell you for the tests, the special words which the patient tells you is the 100% indication of the subarachnoid hemorrhage. Test goes like patient comes to you with a hemorrhage, with a headache after trauma or something like that, and he tells you he has the worst headache of his life. When you hear that, not in the real patient, but in a test, definitely, the worst headache of my or his life is the main thing that gives you the hint about subarachnoid hemorrhage. So remember, worst headache of my life. Okay? Now you have to look at the intracerebral hemorrhage. The hemorrhage which happens inside the brain tissue, which usually results because of the damage of the vascular, like blood vessels of the brain, the vasculitis, or maybe very high blood pressure, which ruptures it. So look at that, that's a small hemorrhage intracranial. That's a bigger hemorrhage, and as you see, the blood, like it started here probably, and then it spilled out into the lateral ventricle and the third ventricle. In here, there's like comparison, the same guy, the 2 hours after onset and 6.5 hours after onset. Look at that, 2 hours after and 6 hours after onset. Like how much of hemorrhage is there? I don't really know why didn't they do something in those 4.5 hours. I'm not sure. And the herniations, I think we're done. Yes. Just a moment, and you'll be happy, and I'll be happy, and everybody's gonna be happy. Herniations. Ethar, I think, had a case about that. Herniations. What is the herniation? Now, herniation is the moving of the brain tissue out of the place where its place actually is. So remember, I showed you the falx cerebri, the 2 layers of the dura in the middle. So that's the falx. There's also the same thing between the brain, between like cerebrum hemispheres and the cerebellum in here. See that? And it's also, isn't called the falx cerebri, it's called the tentorium cerebelli. So this guy and this guy both are produced from dura mater and are much harder than the brain tissue is. So if I increase the pressure somehow in here, I increase the pressure. How can I increase the pressure? I can make the brain swell and increase the pressure. I can produce a hemorrhage here and increase the pressure. I can make a trauma and increase the pressure, and so on and so on. I can put the tumor in here and increase the pressure. Doesn't matter what is the reason of increase the pressure. Herniations happen because of the pressure itself. So I increase the pressure here, so I'm pushing actually the brain towards like this direction. Now where would the brain go? This is a bit free space, but this is not free. If I'm pushing the brain down, the brain cannot go that way because there's a hard surface here. If I'm pushing the brain to the other side, brain cannot go this way because there's a hard space here, hard something here. So it has to like sneak below it. Look at that, it sneaks below the hard something. Imagine a fence which has a hole in the like lower, so you cannot go through the fence unless you're the ghost or like Arnold Schwarzenegger. So you have to sneak in that hole. The same thing. So this guy sneaks in there. So that is called a subfalcine herniation. It's a subfalcine. It is below the falx herniation. Why is that a problem? Because that part of the brain will become damaged. And frankly, this is a very good part of the brain. It's a pretty good part of the brain. So you don't want to really lose it. So subfalcine herniation is very common, and usually the signs are headache and contralateral leg weakness, because here is the motor and sensory part of the leg. Now this is a transtentorial herniation. Now why? This guy cannot go there, he has to sneak here. It has 2 names, transtentorial, or like goes past the tentorium cerebelli, or it's also called the uncal herniation, with or like UNCUS, uncus. This guy is called uncus. It is also extremely important because when it herniates here, it obstructs the oculomotor nerve and gives you a dilation of the pupil, and it's extremely important. So it's like a symptom of the herniation that you see very easily. Look at the patient's eyes. One pupil is dilated. Damn, you know he has a herniation. Open him up as fast as possible. Do the CT. Open him up. Okay. And also contralateral hemparesis. There's like different mechanisms to that. We can talk about that later. And the third one, subtonsillar, tonsillar herniation, not very important. I'm going to tell you the fourth one, which is extremely important when the brain stem herniates into the foramen magnum. Now, why is that a problem? Because if the brain stem herniates into the foramen magnum, there will be an obstruction of the medulla oblongata and damage of the medulla oblongata. And medulla oblongata controls the breathing and the heart rate. So if there is a strong herniation of the brainstem into the foramen magnum, the guy is gonna stop breathing, it's gonna stop the heart, he's gonna die in a second. Okay, this is the most important. This is the most important. So how can that happen? I'm just gonna tell you that, and that you can just go away then. Remember that if somebody has an increased intracranial pressure here in the head, and you make the spinal tap with that patient, which means taking the cerebrospinal fluid from the spinal cord, you decrease the pressure down because you take the fluid. There's an increased pressure here. Increased pressure gonna push the brain down, and it's gonna push the brainstem down, and you're gonna herniate and kill the patient. When does it happen? It happens when there's a tumor in the brain and you're doing the spinal tap. Why do you do the spinal tap? Because the patient has a headache and you think that he has a meningitis, and the main thing you can do to diagnose meningitis is the spinal tap. So if somebody has a headache and you think he has a meningitis and you know you have to do the spinal tap, before you do the spinal tap, it is the main thing to know. You have to rule out a cancer. You have to do a CT of the brain. Make sure there is no cancer. There is no high pressure in the cranial vault, and then you can do the spinal tap. Because if you don't do that, and he has a brain tumor, and you do the spinal tap, your patient has a big chance to die, and then you're gonna go to jail. Okay, so remember that, please. Okay, I think we're done. I think it has been interesting, at least for me. I'm gonna actually save it. So see you guys tomorrow, and I'm gonna ask all of that tomorrow, and I'm gonna ask more. Watch the videos of Kaplan, read the book. Goodbye. See you.